Good afternoon and welcome back. Good afternoon. Good afternoon. Good afternoon. Good afternoon. We seem to have a bit of an echo. Good afternoon and welcome back. Following our previous session on diagnostics and treatment updates, myself and Helen are delighted to be joined by Hassan, Nigel and Rob. Over the next 20 minutes, we will be conducting a conversation following the questions that have been submitted by the audience to our three speakers. And this is a great opportunity for them to respond to these questions and continue into a discussion about the topics that we discuss. I'd like to start the session by turning to Helen, who I know who would like to start with a question to Nigel.
Thank you, Gary. Thank you very much for a really great presentation, Nigel. Liver transplantation for cholangiocarcinoma is something here in the UK we've hoped to get into the cholangiocarcinoma treatment armory for a considerable amount of time. So this is very positive news for those eligible patients. However, what I'd like to know from you is, can you put a time scale on when transplantation for these eligible patients will actually begin to be considered as a realistic treatment option at their MDTs? And then when do you think this will actually, when are we going to see our first transplant for a cholangiocarcinoma patient?
So I would have thought we will have the program up and running within a year. I mean, it was accepted at the end of last year that this was something that we would take forwards. Obviously, COVID has interfered with the running of liver transplantation in a huge way. And whereas at the beginning of last year, we saw waiting lists coming down, there seemed to be more organs around, there seemed to be less pressure on getting patients transplanted. That situation has changed. The waiting lists are long again. There's been an interruption to organ supply. So I think people have been wrestling with those short-term problems. But now the Liver Advisory Group is having an implementation group to take it forwards from what was agreed into the actual nuts and bolts of a plan to take things forwards. In practical terms, I think the waiting list will have to come down. We have to see organ donation being restored to the high levels that we were seeing 1 to 2 years ago. And if we can work through those patients who are medically urgent, where treatment is life-saving, then I think we can come back to cholangiocarcinoma as an indication.
So we've still got a little bit of waiting to do.
I think so, but I think the end is in sight to start. But, I think that is only the start. And then we've got the practical problems. How do we identify patients early? How do we get clinicians to agree, I can resect that, I can't resect that, that should go forward for transplant? How do we have a national network to guide patients in terms of how best to treat them? And then the practical side, how do we get them transplanted in time?
Yeah.
So, I think there are still more hurdles, but it's like everything, it's starting to make an impact and to provide hope and to show the way forwards. I think that's, to me, I'm very optimistic going forwards.
That's a good answer, and hope is so important.
Yeah.
But we're still a little way out. Actually, that, in my mind, sort of segues into a question that I'd like to put to Hassan, if Gary doesn't mind if I carry on a bit further and hold this a bit. Hassan, one of the things that I think we've talked about several times, and I'd like to put to you again today, is the situation with getting inoperable patients downstaged operable? Because we know that transplantation, it'd be great to have it in the treatment armory, but it's not the magic bullet for everybody. Maybe not ideal for everybody, but bearing in mind that resection is still really and truly the only potentially curative treatment that we've got. Why don't we, really focus a lot more on those people who maybe are that sort of borderline inoperable, to get them downstaged and get more people operable? And I know this probably is the thing that comes round again to centres of expertise and so on, but what are your opinions on getting people downstaged?
Thanks, Ellen. I think this is multifactorial. So there's various components of inoperability. So one is around frailty and patients not being fit enough for a major undertaking, which might be a major hepatectomy, but also a liver transplant in the future. The other aspect is around the presence of incurable metastatic disease, which would make surgery futile. So I think those are the areas we need to part to one side. The bit, I guess, what you're trying to get at is that decision making, which is around a locally advanced tumor and what may be operable in one tumor board versus another tumor board. I mean, what I've been reassured by is the earlier talk today that there is consistency with regards to surgery across the various cancer networks in the NCRAS data. So that is reassuring. But I've already put this to Shahid, is that consistency the same for the perihilar cholangio versus the intrahepatic versus the Whipple? Because overall there may be consistency, but there's subtlety to the data which may not have been explored. And different tumor boards have different levels of aggressiveness and things like that. The other aspect is around oncological treatments like systemic chemotherapy. We certainly know from historical data with doublet chemotherapy that response rate is in order of 25-30%. So you may get patients who've got technically borderline operable disease where if you can just shrink it down a bit, then it may become operable. As I'm sure aware, and I'm sure the oncologist will deal with later on, is around the role of neoadjuvant chemotherapy. And Liverpool, for some time, has been working on a neoadjuvant chemotherapy randomized trial, which again has been a victim of COVID, amongst many things. But I've been reassured by my oncology colleague that it should be starting up either later this year or early next year. And that will tell us whether systemic chemotherapy can bring more patients to surgery. But I think the key message, and it goes back to what I was talking about, it's important that your X-rays, your patient scans are seen in the tertiary MDT where that decision can be made. And of course, there's the opportunity for a second opinion if you felt that you wanted to explore that, and I'm sure that's also available. I hope that kind of helps.
Well, it does. Thank you. And I think, yes, the opportunity of second opinion should be given to patients so they can be absolutely certain that the treatment pathway they're being offered is the right one for them. And, we at AMMF hear so many times of patients being told, straight off, no, you're not operable. But what that means is you're not operable here. That doesn't mean you're not operable somewhere else. And I think that's the big shame, that people don't get that second opinion and don't have the courage or the knowledge to go forward for it. So, and that leads us on to all sorts of situations about the centres of expertise and all that, which I won't go into now. But something that I would like to just put past you and just, again, get your opinion on is, and possibly Nigel as well, that shouldn't all patients who were that sort of slightly borderline, maybe operable, when they do go into their chemo, when they have their sort of mid-stage, is the chemo working for you or not, should they not, if it comes back at, yes, you are getting really good response to your chemo, should they not at that stage be reconsidered again for surgery?
Oh, I completely agree. I mean, again, it's about having a properly integrated system. So if you take the analogy of metastatic colorectal cancer, which as mentioned before, is a very common cancer, all these, certainly in Liverpool, all these patients are initially seen in our tumor board. Then decisions are made, they're sent off for systemic chemotherapy, and then they're brought back for further assessment. So, you know, if someone's been sent for systemic treatment, having that image rediscussed at the cancer meeting or the surgical HPB meeting is crucial. But I think it's also important that at the get-go, there's a kind of decision around the intention of the treatment. And sometimes, unfortunately, the intention will always be palliative in nature. But I think it's also important not to miss those patients who could be salvaged and offered a chance at cure.
Maybe I could just say something. I'd like to turn it around a little bit. The majority of patients are not going to have curative disease at presentation. So I think there needs to be a focus around earlier identification of the patients. But I remain to be convinced that patients are referred in a timely way. They're then labeled as requiring palliative treatments. They're given a dismal prognosis. And I think we really need to focus on these patients, because they need to go to energetic clinicians who are going to optimize the various therapies that they may be able to tolerate and gain benefit from as early as possible. And I'm just not convinced, even around the standards of stenting and those sorts of things, are they really getting excellence in their care? I don't see it. I don't believe it. And so I think that's a big patient population. We really need to focus on those patients.
Absolutely. Yeah. Well, we need the data to support what we all know is happening, so that we can push forward for improvements. And hopefully our data project, AMMF data project, will go some way to that. I'm going to hand back to, thank you both very much for those erudite answers, and I'll hand back now to Gary.
Thank you, and a great discussion to start this Q&A. I would like to take this opportunity now to turn to Professor Goldin and respond to one of the questions we received during the session. The question we have is, do we know the reasons for the geographical differences in the incidence of gallbladder cancer?
That's a great question, and the answer is ever, we know a bit, but not enough. I mean, you know, the extraordinary incidence of gallbladder cancer in Chile and all the way up the Andes. You know, in Chile, gallbladder cancer is the commonest cancer in women. It's an extraordinary figure. In India, particularly North India, very common. So, I mean, we do know something. We know that there are probably almost in genetic factors at work. Certainly in Chile, it's very much more in the indigenous Amerindian population, who may have, for example, genetic abnormalities in bile salt metabolism, which might play a role. But there are also infectious causes, both in Chile and in India. Salmonella is clearly a significant risk factor for gallbladder cancer. Helicobacter infections have even been suggested. But really, after that, a lot of things have been raised. Eating too many chili peppers is the kind of, you know, point that people raised. There's probably a little bit more to be said, but that's the basic answer. As always, genetic and environmental factors, and we need to know more.
Excellent. And just to build upon that question, you mentioned in your presentation the need to frequently examine or monitor the gallbladder, and if that was to become routine, how routine should it be?
So I'm not quite sure what you mean.
So in the question that came through is, how frequently should the gallbladder be examined or monitored for?
Do you mean exam? Well, yeah, I mean, I think it's a big, you know, there's a common theme in all these talks, isn't there, that you know, that things need to be done ideally. It's not always practiced by specialists and specialist centers, because to do these things properly takes a lot of work and takes, you know, a particular interest. You know, it's been a privilege for me to work with, you know, with groups of Chilean pathologists who really are absolutely devoted to getting the best results for their patients, extracting every last drop of information. Whereas here, you know, they are buried in large numbers of cases which carry no significant pathology. And we have to find a strategy to make sure that those patients who are unlucky enough to have gallbladder cancer, which is frequency is not in debate, have them done properly. I mean, I think, you know, the figures I've given are the ones I'd stick with. You know, we need to be prepared to spend a lot more time and effort than we have up till now.
Thank you. Excellent.
Could I come in there? There was an interesting question put to Shahid Khan this morning, which was, if you've had problems with your gallbladder or your gallbladder removed, does this then leave you more likely to develop cholangiocarcinoma, for whatever reason? But so that's part of my question to you, Rob. But the other part would be, have you ever been examining, gallbladder tissue and actually spotted a cholangio?
What cancer in? Well, I mean, yes, there is. First of all, take first question first. Others may have more direct clinical experience, but we know that a number of biliary diseases are a field change. I talked about some of the intracholecystic papillary neoplasms. Why aren't all the patients cured? Well, that's because they develop seminal lesions elsewhere. But in general, the risks are certainly, very low for field change, and obviously very difficult to follow. But I'm very interested to know what my clinical colleagues think about that. So, your second question was?
When you've been examining gallbladder tissue?
Yeah, we do. I mean, it's very not. I work in the specialist centre. I accept that, but to see a gallbladder taken up for chronic cholecystitis, which has quite advanced gallbladder cancer, is not uncommon. And the other way around, we see many gallbladders taken out, for query cancer or probable cancer, and they are just gallbladders which are perforated into the liver bed, and there's a lot of foamy reaction to it. It cuts both ways. So obviously I feel pathology has an important role to play in everything we do, but I think it does here as well.
Helen, can I come in at this point, because I think this is quite an important issue. Sunny, what we as liver surgeons see, we do get referred patients who've had an incidental gallbladder cancer found for a cholecystectomy for assumed benign disease. And part of the difficulty is that, okay, if it's an early stage tumor, often you've taken the gallbladder intact, and that's great. But sometimes when the disease is a bit more advanced, the gallbladder is removed piecemeal, and that makes any subsequent attempt at curative surgery for these patients futile. And so one of the messages that we've been trying to pass out to the general surgeons in our region, because in the UK there's about 60,000 cholecystectomies every year for mainly gallstone disease. The incidence of gallbladder cancer is probably about 600 cases a year, and not every cholecystectomy is done by a hepatobiliary surgeon. So the message we've passed to folk in our region is that if on your ultrasound imaging this concerns raised, refer to the tertiary MDT. If when you go in to do that cholecystectomy and the gallbladder looks abnormal or concerning, stop, don't proceed with trying to remove it piecemeal, refer that patient into the MDT so we can then plan that operation with optimal staging and in a way that we remove the gallbladder intact. So if it is a cancer, we've removed it without compromising the tumor margins. And I think that is an important message.
I think so too.
Thank you, Hassan. And I'd like to build on that point by Hassan for a question to Nigel that came in from our audience during your presentation. When do you think liver transplantation may be available for cholangiocarcinoma patients in the UK?
So I'd say 12 to 18 months.
That was a very quick answer. Thank you very much.
If I can just reply to Rob's question, one of the problems in dealing with HPV malignancy in the past has been the poor survival of patients. But as you see patients extending beyond 5 years, actually second cancers in the field change do become much more common. And so, the standard format is follow patients for 5 years and then you're cured and discharged. I don't believe that. And I think particularly for cholangiocarcinoma and pancreatic cancer, once you get to 5 years, you should be continuing on for long-term surveillance for second tumors. These are valuable, precious patients that we've got through all of this. Let's look after them for the long term. And I think then field change does become apparent.
That's another incredibly valid point, and I know it's probably one that Hassan really agrees with because he follows his patients up for a considerable amount of time, and it's something is a question that we are asked many times, what is the follow-up protocol? And there really doesn't seem to be a very good one, because it depends who your surgeon is, who's what centre is managing your treatment and your care. I mean, we have people coming to us saying, I've been told after a year that I don't need, I had my resection a year ago, I now don't need to be scanned anymore. And, it's crazy. I mean, we know that 5 years, 6 years down the line, people can get recurrence or second cholangio can turn up again. So I think it's sort of leading us around to the fact that we really badly need new guidelines on diagnosis and treatments and all sorts of protocols for follow-up, for this, for that, and everything. It's all very badly needed in this area.
So sorry.
I think people will argue, Helen, where's the evidence base that follow-up and surveillance makes a difference? And whilst I accept that, I think that is a very nihilistic approach. For patients, they often find it's extremely stressful when it comes up to CT or screening or whatever it may be, their tumor markers. And so I think we probably need to give people an option. But I think these patients should be followed up. I think as we develop better therapies, be it chemo, radio, or other ablative or treatments, actually early identification of recurrence may make a difference to survival. So I think we're in a tipping point, and I think particularly with cholangiocarcinoma, it's so rare. I think we should be following patients up and doing everything we can to alter the prognosis.
Can I just add 3 quick points? So firstly, radiotherapy treatment for oligometastatic disease is now licensed in the UK, and this would include cholangiocarcinoma. So for a small subpopulation with limited metastatic disease, there is a therapeutic option that is designed to destroy that recurrence and potentially offer chance of cure. So we do need to follow these patients up to identify that. The other thing to mention is that the way we follow patients up may evolve and change as technology changes. So there's a lot of interest in circulating tumor DNA and whether that type of technology could be applied to this disease rather than the traditional tumor marker or the scan. Finally, this type of surgery that we're also talking about, where you've done a hepatocogeginostomy or biliary anastomosis, often there's a longer term morbidity associated with these types of operations. And so from that point of view, and this morbidity has got nothing to do with recurrence, it's still important to follow patients up so that those complications in the long term can also be managed effectively.
Yeah.
Thank you, Hassan. I'm going to have to end the Q&A there. It's clear we could continue this conversation for hours. I'd like to, on behalf of the AMMF, thank our 3 speakers for making yourselves available. I know, Nigel, you went out of your way to be where you are today to attend this session. So thank you all. I appreciate your contributions, and thank you for all that have joined and asked your questions. And we will make every effort to respond to the questions that haven't been responded over the course of the coming weeks and months. Thank you all, and look forward to seeing you in the next session.
Thank you, everyone.